Well, good morning. It's absolutely my pleasure to be here. I think this is about my fourth visit to Stockholm in the past few years. As you can tell from the bags under my eyes, my role at Microsoft, I travel the world. And one of the advantages of that is I get to see a lot of things. I'm also thrilled with the people over here in the cage because I'm a huge advocate for younger people being involved in solving some of these problems. I think too often in digital health we look to the old gray-haired men and women in the boardroom to fix this, and that's not who's going to fix it. It's going to be these smart young people, so that's good. So what I'd like to do this morning is share with you a little bit of a personal journey, not only about some of the things we're doing at our company, but again, just some observations about what I see around the world and also some of the things that I've been involved in over the course of my rather long career of about 35 years. So let's talk about what I've learned about healthcare and technology, business and human behavior. Now, before I do that, a little about me, a little bit of a story. So this is where I grew up. This is called Gig Harbor, Washington. It's about 50 miles southwest of Seattle. You can see it's a beautiful place with mountains and water and boats and fishing. It's very much like Sweden, actually. Lovely place to grow up. And this is my family. I'm an only child. I often refer to the little guy there on my dad's lap as my little brother. My dad and mom, neither one of them had gone to college. They wanted their only child, me, to become a professional. They wanted me to become a dentist. After spending a little time with a dentist, I decided that wasn't what I wanted to do. So in my college years, I actually got sidetracked a little bit. I was pre-med, but got sidetracked in the broadcasting arena. I actually produced and hosted a television show for teenagers all through college. But it eventually get around to going to medical school, and here I am as the newly minted medical graduate in about 1979. And you might have guessed the year by looking at that very fancy camera my wife is holding, the famous Polaroid SX70. Imagine you could take a picture and see it right away. You guys in the cage, think of that, seeing a picture right away. Yeah, okay, that dates me, doesn't it? Now, when I was in my senior year of residency in family medicine, I came across this, and I really, really wanted it. Of course, back in the day, it would cost about 2 months of my residence salary, and so I had to convince my wife why this would be a good idea to buy one of these. So, of course, I told her that computers were the future, and that I could learn how to program, and it would be a really cool thing to do. And she let me buy it. But of course, what I really wanted to do was play video games. But I did actually do some programming and learn some interesting things about computers, which actually played out very well as my career progressed. All right, my professional journey as a doctor begins. Of course, when I started practice, everything was still on paper. And you might be surprised to learn that if I go back just maybe 3 or 4 years in the US, which sometimes people think is an advanced place, I will tell you in health IT, it's not necessarily an advanced place. In fact, the Nordics have been way ahead of us in the US and Canada and other places I can think of for years. But if I go back just maybe 4 years, 5 years ago, about half of our doctors in America were still doing their work with pen and paper. Now, the US federal government, through Obamacare and something called the High-Tech Act, has invested about $30 billion over the past couple of years to drive adoption of electronic records. And indeed, that's happened. But would you believe, this is the most latest number, the usage in the USA is now 83% of doctors. That means about 1 in 5 doctors are still doing their work on paper in the US. As the years went on, I mean, this is the kind of electronic record I started with, very DOS-like, not very interesting, terrible user interface. Electronic records have indeed improved, but most of my professional colleagues still complain about them. The user interfaces are not ideal. They don't allow for data input options that doctors would like to have, and frankly, they do kind of get in the way of patient care. One of the things now doing the work that I do in a large tech company that I tell my colleagues about is the way I work compared to the way they work. Now think about this. Healthcare is a business of communication and collaboration, care team collaboration, patient collaboration, communication. Most medical mistakes actually happen when communications break down, and yet it's still a paper, phone, and fax world in healthcare. Now, the way I work today, and probably many of you work, is quite different. No matter what device I happen to pick up, I have applications that I can use. I can move from messaging, mail, voice, video, multi-party web conferencing, click, 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 anywhere I am. But that's unheard of in healthcare. Why is that? We need these tools in healthcare. Now, I mentioned that I started my career in television broadcasting, and as luck would have it, when I became a physician, because I was so well known for doing television, those two careers kind of came together. And for 20 years, I worked for some of the large American networks and actually worked for a program for physicians that was broadcast all over the world for many, many years. And I was always fascinated by this concept of telemedicine and how it could impact, basically, patient care. Now, there's nothing new about telemedicine, right? It's been around since probably the 1950s. It was big, bulky, expensive, cables and big cameras and studio lights. But in about 1998, I had this idea, as I saw the internet coming along, that we could use the internet to do telemedicine. So we got some venture capital, and working with Microsoft, we actually built a system that would allow patients to go online, make an appointment with their doctor at the appropriate time, hook up with their doctor, see and hear each other, gave the doctor tools to document the entire visit, and we actually had a business model from large self-insured companies that would pay for the visits. Wow, nirvana, amazing. To the young entrepreneurs in the audience, I will tell you that being early with an idea is just as bad as being late. Because, of course, what happened was the idea was right, the technology worked but wasn't quite yet good enough, the business model worked, but the world just wasn't ready for it. So, lesson learned, being early is just as bad as being late when you have an idea about digital health. Now, today, there are dozens of companies, some of them quite successful, in fact. This is a US company, but around the world, there are companies now in this space providing sort of the network capacity to bring patients and doctors together over the internet. There are even companies that specialize in working with pharmacy chains like CVS and Walgreens and others, where basically they have kind of a special room that you can go into where there's equipment where we can actually start doing physiological testing on a patient at distance. And in fact, I'd urge you to go to the, I guess it's your left, my right side over here, and in the hall under our banner, to see some work that's going on here in Sweden, which I think is very encouraging. The idea of putting health rooms in rural areas, often based in schools or similar settings, where 24 hours a day people can go, connect themselves to some equipment, and monitor their health and even see a doctor online. The only thing I would challenge and say is, why only in rural areas? The case is made that, well, people in rural areas have to get in a car and drive someplace, and it's really hard for them, but have you tried getting across Stockholm in traffic? I was trapped in traffic, it seemed like forever yesterday. It's just as hard to go across Stockholm as to drive from some rural area in the hinterlands. So why don't we have health rooms available all over Sweden? This is the vision. This is what we can do. And you know that there are organizations, primarily managed care organizations in the US, that have really embraced telehealth and telemedicine. And the studies are beginning to show that we can virtualize about 25 to 40% of the patient impact on our healthcare facilities. So in other words, 25 to 40% of the time, we can care for a problem without the patient necessarily physically being there. For minor illness, for quick checks, for surgical rechecks, lots and lots of things. So I really encourage the city councils and county councils and the Swedish government to embrace telemedicine. It's time to stop the pilots. It's time to implement these things for the population because it's so efficient and it really can improve care and access to care. And as I said, I write a blog called Health Blog, and a couple of weeks ago I did a little write-up about this health room project that I've seen here in Sweden, which I really applaud, and I'd like to see more of that. The other thing I've learned about technology in healthcare for clinical end users, doctors, nurses, and others, if the solution isn't mobile, it really doesn't work. Doctors and nurses move around all the time. They're constantly on the move, and yet we force them into very unusual workflows by saying, here's the nursing station, here's the desktop, go do your work. That doesn't work very well. Today we have not just devices that my company makes, but across the board, lots of really beautiful mobile devices, tablets, and so forth, that doctors can interface with and use with a patient much like they use with the chart. I can walk through the door. I know about my patient. I sit down. The technology doesn't get in the way. It doesn't come between me and my patient. And I've heard time and time again, doctors who are using these lighter weight, great tablets today, that they say two things that I say are the money line. That is, one, I can see a couple more patients a day, that's a good thing. Or two, I go home at the end of the day and my work is done. When I hear doctors saying that they can see a couple more patients a day and they go home and their work is done, their charting is done, that's a very good thing. Now, today we're talking about tablets and smartphones and so forth. Looking at the work that we and other companies are doing, I project ahead a little bit and say, eventually I think we'll get to kind of a deviceless state where basically the environments we are in, the rooms we are in, simply become alive and listen to us. And we have virtual assistants like Cortana and Siri that basically are at our beck and call. And a lot of our documentation, a lot of things we need to do will be done by these virtual agents, keeping the doctor's hands free and able to move about. Another piece on from my blog. Future Hospital, here the tablet is also having a great effect. The tablet is becoming the nurse call device. It's the device for entertainment. It's the device for patient education. It's the device for filling out surveys, for Skyping with friends and family, etc. And in many cases, in some of our hospitals, in chronic disease cases, the patient is then sent home with this tablet where it becomes that beautiful, transparent piece of glass that continues the conversation with the hospital. I think that's really a good thing. We have great partners. This is one view. If you ever visit the new UCSF Hospital Mission Bay or the Chris O'Brien Lighthouse in Sydney, Australia, or if you go to Dublin, Ireland, where this company actually is based, you'll see the work they're doing. New hospitals coming out of the ground, big LCDs on the wall, tablets, patients having this experience of connection with friends and family, patient education, entertainment, sort of the hotel experience, and the ability for that thing to pivot and become the electronic medical record that the staff uses. Of course, now that we're capturing all this data, and if any of you are in administrative or executive roles in hospitals, I know there's a lot of consternation about electronic medical records. I know that decisions are being made about buying and building some of these really expensive new systems or ripping and replacing EMRs. And when you're spending that kind of money, it's very common for the executives going to the board or the government and asking for this money to say, once we have done this, we will have transformed medicine. We'll have transformed patient care. It will be amazing. When, in fact, all we've done is taken what we used to do on paper and digitize it. And as you heard in the talk before me and the comments from the people in the cage, basically this is very true. Yes, we have lots of digital data, but are we using it to improve health? Are we using it to achieve the triple aim of lowering cost, improving access, and basically improving the quality of care? That's what it's about. And it's not the EMR that does that. It's how we use that digital information. So how we use advanced analytics. Not analytics for data scientists, but analytics that are drag and drop and easy to use and beautiful, intuitive user interfaces that give us insight to what's really happening with our patients. Even more so, predictive analytics that can look ahead at not what is happening, but what's going to happen. We have tools today that will do that. I also do a lot of work with Singularity University and some of the advanced research labs around the world in the realm of machine learning, machine vision, and artificial intelligence. We have been quite good at predicting the future at our company. I could show you a video we did 10 years ago that people said, oh, that won't happen in my lifetime. And in fact, everything in that video has come to be. If I look forward another 10 years and knowing what our researchers at my company and others around the world are doing, if I'm a physician and I make my living by being purely visual. In other words, I'm a pathologist, a dermatologist, a radiologist. I look at something, cast it against what's inside my head, and make a diagnosis. I believe that over the next decade, things are going to change mightily in that the machine is going to be so much better at looking at almost anything, casting its intelligence against millions of vetted images in the cloud and coming up with a diagnosis. Now, that doesn't mean the machine replaces a doctor, but it does change what doctors do. The same can be said of someone who is purely cognitive. In other words, you take in a lot of data, I do tests, I do examinations, I just get a lot of data, I cast that against what's in my head, I arrive at a diagnosis. We know oftentimes those diagnoses are sometimes wrong, and I believe here too, the machines, and you're seeing with IBM Watson and some of the work that we are doing, and other companies, you're beginning to see how the so-called singularity will happen when the machines actually get just as good, if not better, than the humans in all of this. We're doing some work with Dartmouth-Hitchcock, which is a health system affiliated with Dartmouth College in Vermont and New Hampshire area of the United States. And they're applying some of our latest advanced analytics, something called the Cortana Analytics Suite, along with a lot of other technology, and applying it to manage their population of patients. They've always excelled at doing managed care there. They've done a very good job. But they're taking it to the next level in using all these amazing tools to, well, let me show you what they're doing. Watch this.
With the help of Microsoft, Dartmouth-Hitchcock is building a technology platform to serve healthcare organizations and patients across the country. Now, using machine intelligence, providers can develop a care plan that's unique to each patient. We can monitor patients from their homes, where data is collected from devices and sent to the cloud, to ImagineCare's 24/7 contact center, where registered nurses continually monitor a patient's health status and potentially serious trends.
Cortana, summarize health status for Ben Andrews.
Ben Andrews' weight has increased more than 2 pounds in the last 24 hours. Please review the home diuresis protocol prescribed by Dr. Phillips.
Patients get reminders and encouragement and dynamic updates to their care plans, improving their health, helping them avoid unnecessary trips to the emergency room, and reducing the cost of care.
Now, lest you think that is just some sort of fanciful vision, in fact, Dartmouth will be enrolling the first 6,000 patients in October, and we'll soon learn how this affects population health and managed care. You know, for all the talk about hospitals and clinics and doctors and nurses, let's face it, where healthcare really starts is in our homes. It's usually the woman of the home, the mother often, who is the manager of healthcare in the home. So what are we doing to bring and improve healthcare in the home? One of the real pleasures I have working at the kind of company I work at is that I get to see things that, now mind you, we are not a healthcare company. We're not a health company. We don't necessarily build solutions that are out of the box made for healthcare. But it's amazing to see how some of the things we invent end up having a big play in health and healthcare. Example is, you're probably familiar with this, the Kinect sensor. Now trust me, nobody at our company was thinking about health and healthcare when they made this device. They were thinking about gaming. But here's this device, and I saw it early on in the research labs, and the teams told me about what they were doing. It was going to have a depth perception camera, an array microphone. It could study the human body. They would create games that would teach people to dance in their homes. Now, when doctors hear this, or nurses, or people who work in healthcare, you go, well, if you could teach someone to dance in their home, what else could you do with this? Well, in fact, almost every country that I visit has somebody doing work in physical med and rehab. And that's just one of the examples where this Kinect device is being used in health and healthcare. Now, if you have a broken leg or a bad back or been in an automobile accident, do you want to be getting on planes, trains, buses, and automobiles and going back and forth to physical therapy? No. Wouldn't it be better if we could start physical therapy in the traditional setting and then move it right into your home and the doctors can monitor you and do what they need to do? Yes. And that's what the Kinect is making possible. Wearables are exploding. They are everywhere, you know, and this is just one of them, one of the ones that we happen to be involved with. But one of the things that I like about where this is taking us is not only are these wearables starting to look at our fitness and our, you know, activity levels, but in the case of this thing we call the band, which I'm wearing and some of our staff are wearing, it combines both my home life with my work life. So it also knows my calendaring and my scheduling. It's a very sophisticated device. If I can get the slide there. It has 10 different sensors in it, onboard GPS. But what's really cool about it is it's cross-platform. So this device works on iOS, it works on Apple phones, it works on Android phones, and it works on our Windows phones. And by combining home life with work life, for example, if I do a sleep study with this device, go to bed at night, push a button overnight, it monitors my sleep. I'm a notorious poor sleeper. In fact, I've been up since midnight, so if I start rambling, you'll understand. When I do sleep studies with this, it gives me a lot of information about my sleep, but because it also knows my calendar, if I was out drinking with my team last night, it might give me some useful insights that perhaps the wine I drank also affected my sleep last night. That, by the way, wasn't the case last night. Lastly, let me tell you about this. So I told you about how Connect found its way into health and healthcare, and not just in physical med and rehab, but actually in imaging and radiology, in surgical suites where people are using the Connect. You know, as a surgeon, you're scrubbed in and you're doing your work, and I'm barking orders at somebody over there who has a mouse and a keyboard, and they're trying to get the images I need to see to do my operation, and soon I get frustrated, I break scrub, and I go over and do it myself. Well, with the Connect sensor now, what they can do is basically just gesture, and they can get it exactly what they need. That's another example of Connect. But let me tell you about this. We introduced this a few months ago to the press. It was actually a Windows 10 kind of pre-launch event, and we thought it'd be cool to throw this in and kind of excite the press. I think it might have been a mistake because the press was so excited about this, they forgot to write about Windows 10. But at any rate, and I understand why. This is HoloLens. This is augmented reality meets holographic computing. Some of you may have seen this. This is another example where, trust me, nobody in the group who developed this over the last 10 years was necessarily thinking healthcare. They were thinking gaming and maybe some industrial applications, but not necessarily healthcare. But guess what? Every physician, every nurse, every health educator that has seen this and what it does says, this is going to change healthcare. This is going to change surgical planning. This is going to change imaging and radiology. This is going to change medical education. We're doing some work with, not with Dartmouth-Hitchcock, that was the last one. We're doing some work with the Cleveland Clinic and Case Western Reserve University. They are building a new medical school. Cadavers are expensive and hard to find sometimes. You have to have a big lab, and people who are in medical school, I had a cadaver when I trained, but it's complicated. Case Western and Cleveland Clinic, in building their new medical school, are going to be using the HoloLens to teach anatomy and physiology. Watch this.
Now, Mark is part of a team from Case Western and the Cleveland Clinic. We invited them to use Windows Holographic to advance medical education beyond what is possible with today's state-of-the-art. Take it away.
Thanks, Alex. Today we use a combination of cadavers and medical illustrations to teach students anatomy. This is a curriculum that hasn't drastically changed in over 100 years because there simply hasn't been another way. The mixed reality of the HoloLens has the potential to revolutionize this education by bringing 3D content into the real world. Now, one of the biggest challenges for students learning anatomy is understanding the body in 3 dimensions and how all the different systems fit together. Using holograms, we can easily separate and focus in on individual systems. For example, we can focus in on the femur, and students can immediately see some of the types of fractures they may one day encounter in the clinic. Now, I can leverage all of these new capabilities while maintaining the important connection with my students. When we're both wearing a HoloLens, I can see what they're looking at, what they're interacting with. I can assess their progress, and they can communicate with me and each other naturally. For example, I can see if Michelle has a question in class, or whether Gwen has a question while learning remotely. Now, obviously, a cadaver doesn't move. This makes it difficult to see the way a living body actually works. HoloLens doesn't have this limitation. Systems can be animated to easily see how things function. Let's take a look at the center of the cardiovascular system, the heart. It's an amazing organ. In reality, it's about the size of your fist. With HoloLens, we can easily scale up the heart to let students see minute details. We can even see inside the heart to see the valves in action. This is a new way of seeing things, and it has the potential to help students understand the structure and physiology of the body in a way that's just not possible today. Now, what you've just seen is a vision of how HoloLens could enhance one single subject. But as an educator, it's easy for me to see that it's not just anatomy that could benefit from this technology. This could change how everyone learns. Imagine for a moment some of the other fields that could be changed. For example, chemistry and genetics, art, engineering, and paleontology. And the best part is, we get to help define that future together.
Pretty cool, don't you think? And by the way, this isn't some future thing. This is something you're going to be seeing probably first in enterprise settings and eventually in your own home in the I can't give you the exact date, but fairly near term, let me put it that way. So what I've learned about healthcare, technology, business, and human behavior, well, technology is now mature. It's ready. We can do a lot. It's not technology that holds us back today, unlike my experience in 1998 with the virtual clinic and Dr. Goodwell. Consumers, patients, expect and deserve better from what they are getting, from healthcare, from doctors, from nurses, from the government. This needs to change. Patient engagement is hard, but it is possible. I've always been a little cynical about patient engagement. I mean, let's face it, my patients didn't look forward to coming to see me any more than I look forward going to the dentist. It's something you do. And we sometimes, those of us who work in healthcare, have this romanticized idea that people want this relationship with us. But when they're healthy and feeling good, the last thing they want to think about is doctors and healthcare and operations and stuff, right? So how do you keep them engaged in the conversation? I think the examples you're seeing here across the board at Digital Health Days give us all an inkling of the kinds of things and perhaps the kinds of incentives we have to have in place so that people will be engaged, not necessarily in love with their doctors and with healthcare, but engaged. And finally, let's face it, it doesn't matter whether you are spending 20% of GDP, as we are in the US, or 11 or 12%, as is common in Europe, or even 5%, as I see in some of the emerging developing markets around the world. Every health minister, every health leader I talk to, no matter how much they're spending, they feel it's too much and it's bankrupting their country. We need to change that. And the solutions we're looking at today and the solutions that all of us are here to deliver into this wonderful opportunity are needed because our mutual economies, the health of our countries, besides the health of our people, depend upon this. Lastly, I've said technology is the easy part. And indeed, I believe it's matured to the point over the last few years that technology is the easy part, but it is still the cultures, the behaviors, the regulations, the rules, the lawyers, and lots of other things that get in the way and hold us back. I guarantee we can usually solve for technology. It's the people part that remains difficult. And finally, I've been talking a lot about amazing technologies today, and I don't want you walking away, oh, this doctor from Microsoft came to talk to us, and it was all about, you know, whiz-bang, virtual this and that, and holograms and all kinds of things. I do not underestimate the importance of human touch in healing. So don't get me wrong. What I'm hoping all this technology will bring us and bring the physicians and nurses and people working in healthcare that I care so much about is give them the time back for the touch, for the healing, and get rid of some of the annoying things we have in healthcare that, frankly, we could do without. I write a blog called Health Blog. It's widely read all over the world. One word, Health Blog. Any search engine will find it. I know you always use Bing, but some of you may turn to Dr. Google now and then, and that's okay too, but Health Blog, all one word. Also, follow me on Twitter, @MicrosoftMD, since we're so social and digital here, right? Okay. And with that, I want to thank you. It has been a pleasure. Thanks for showing up early this morning. And Godspeed, and let's fix this digital health stuff. Thank you.
Thank you, Bill. Thank you for a really insightful speech and also great examples of amazing technology.
Thank you.
I'm standing in line for the HoloLens.
Yes, well, it'll probably be a long line.
Exactly. Well, I have a lot of questions, but I thought, would you like to take a seat or stand over here?
Oh,
we can
sure.
view the panel. See if you have any comments, insights, questions.
Yeah, we had some discussions in here in the cage, we always do. And the first thing that and thank you for the presentation, fantastic. There's a lot going on out there. But we stumble upon the sentence that patient engagement is hard but possible. We don't really agree. We think that it's all about inviting and letting go of some of that doctor control, because most patients do want to be a part. But it has to be a win-win. So I see a lot of monitoring patients and giving my data, but what's in it for me as a patient? If I'm not invited in as a team player, so when you see the picture of the core team, there should be the patient there as well. So if you invite us in, I think we are more than willing to be a part, and we want to be engaged, and we have to be engaged, because it's only for me, I spend an hour with my physician every second year, so most of the time I have to monitor myself, so yeah, I don't think it's that hard.
I think, I mean, first of all, hear you loud and clear, and I agree that we physicians and clinicians need to do a better job of embracing digital health and digital media. You know, one of the things that became apparent to me years ago with the dawn of the internet was that my patients had 24 hours a day, 7 days a week to study their disease. I did not. And it was transformative to me to realize that I was now really on an equal level with my patients in many ways, perhaps with different context, but nonetheless, people have these tools. So I would challenge just a little bit and say, you don't really need to be invited by anyone, first and foremost. Again, most of our healthcare happens in the home, and when you do reach out, yes, I want clinicians to work with you, point you to the good stuff, help you on your journey, but it is a two-way street, and you don't always have to be invited.
Yeah, I think I actually have to emphasize on that as well. I understand Jenny's point of view in this, because I produce a lot of data. As a diabetic person, I actually measure everything from my food intake to my blood pressure to my blood glucose. And I actually have to educate my physician sometimes on my own disease. So I oftentimes find it very strange that technology companies are always stressing out on the physician part and always stressing out on we need to involve physicians and we need to involve diabetic nurses and we need to involve the professionals in the field in developing our products. But oftentimes you see that the real professionals, the patients that are measuring everything, like you said just now, the healthcare starts at home, that companies leave those people out, and that is just wrong in my opinion, because you're developing a product and you're putting it on the market primarily for the patient, because the patient is eventually the one walking around with the illness or the disease, but you're developing it for a completely different group. And I'm not saying that Microsoft is doing that, because I've been using HealthFold for quite a while already, but I see that happening in a lot of new tech companies as well.
Well, first of all, I would love to have a patient like you, because I like patients who are engaged in their care and taking good care of themselves, so my compliments to you. It is a two-way street. I mean, first of all, it's really great that we have all these consumer companies like Microsoft and Google and Apple and others who are now looking at healthcare and thinking about it from the consumer perspective. But I would also say that one of our challenges as, in our case, we are both a consumer company and an enterprise company, and in order to engage the clinical people that we need to engage, we have to make sure that we're creating things that, first of all, they trust. They trust from the standpoint of being clinical grade. They trust from the standpoint of being private and secure, and all the things we have to think about in enterprise healthcare. And at the same time, can be used easily by patients, and there can be lines of communication and so forth. So there's much work to be done. You guys are going to figure it out.
One more, yeah.
Yeah,
Absolutely. So thank you so much. It has been great to have an American perspective on this, because one thing that I think is so important in this conference is this is not a Swedish conference for digital health. This is not a European conference. This is about worldwide digital health. And in the last session we asked, who is our champion? Who's going to push this through? And you said it yourself, you're not a healthcare company, but is it the American tech companies that are finally going to push this through? Are they bold enough, and are you capable enough? Because one thing in Europe is we have so much legislation, there's so much to be pushed through, and is it the Americans that are going to push this through, and then are you capable of changing it also in Europe?
I think you're putting way too much faith in America. Actually, I mean, I probably spend more time outside the US than inside the US, and even though I'm an American-trained physician and I practiced for 20 years in patient care, the most amazing tech that I tend to see around the world is in places like the Nordics, Western Europe. Also, some of the most amazing tech I see in emerging, developing markets. They haven't been burdened by you talked about the legacy of the old wired, clunky stuff that we deal with in our Western industrialized countries. You go to some places in South America, some places in India, Asia, and you see amazing technology, and you go, how did that happen? Well, it happened because, first of all, it's a little less regulated. Secondly, they went straight to wireless, they went straight to off-the-shelf, they use commodity stuff. They don't spend, like we do in America, $500 million on some EMR for one hospital. That doesn't happen. So they're much smarter in the way they apply technology, and they aren't burdened by the legacy of the past.
I think I have to add something to that as well, because when you're looking at the healthcare system, how it's formed in many European countries, we're working with a social healthcare system where also the reimbursement model is actually made on earning money on the amount of patients that you're going to see. And that was especially something that I was curious about in the first part of your presentation, because you were mentioning that you want to bring healthcare more into the home, so actually getting it away from the doctor. But in Sweden, for instance, doctors get paid by the visits of patients that they have per day. So it's going to be quite difficult when you're looking at reimbursement model to change healthcare in many European countries. Also, what I want to add to that as well is that healthcare systems, I'm from the Netherlands, and the Netherlands is seen as one of the bigger countries in Europe where innovation in healthcare takes place. But one of the biggest hiccups that we have right now with innovation in healthcare is the rules that the government is putting on healthcare.
Amen.
Yeah. So when you want to develop something, in my opinion, it would make more sense to start looking from the other side, because we're constantly looking at what can technology bring and what can technology do, and where is it failing in technology? No, it's not failing in technology. Technology is there. Technology is capable of doing anything. Already since 2006, I have been using HealthFold. I've been using USB glucose meters. So everything is there. But it's constantly the rules, the regulation, the law, everything is holding it back.
Remember what I said, today especially, it's not about the technology. We can usually solve for that. However, thinking of the Pope's visit this week to the United States, even the Catholic Church will say, no margin, no mission. One of the biggest mistakes that young entrepreneurs make, and I work with a lot of startups and a lot of young entrepreneurs, and my daughter's involved in the tech industry as well. One of the things, you can come up with the most amazing idea, but if you don't have a way to scale it and to monetize it, it's not going to go anywhere. So I encourage people who are in this space and thinking about, you may have such goodness and charity in your heart, but if you can't figure out a way about who pays and how to monetize, you'll be dead in your tracks. And that's just the way it is. But I agree with you, let's get the regulations out of the way. And I actually had a great conversation yesterday with one of your government leaders here in Stockholm. And I very pointedly said, it's not technology or people's desire that's holding back telehealth and telemedicine. It is the regulatory environment and it is the payer environment. And until that changes, we're all dead in our tracks. he really picked up on that, and I truly believe that government is awakening to the kinds of savings that can be achieved when we start virtualizing healthcare services and yet reimbursing providers for engaging with people in new ways that include mail and messaging and video and web conferencing, et cetera. It will happen.
I think that's a perfect roundup, because that is really what we need to dive into at the next DHD, the whole sort of regulatory aspects of it. But Bill, thank you so much for the insights and the great talk. Thank you.